Chair, thanks, gentlemen. Now recognize the gentleman from Kentucky, Mr. Whitfield, 5 minutes for question.
Well, thank you, Mr. Chairman, and I would like to thank all of the witnesses for joining us today and giving your views on this important legislation. Dr. Stack, I'd like to follow up on the prescription drug monitoring programs as well. As you know, the first program came out of the Appropriations Committee and was placed over at the Department of Justice and was primarily focused on law enforcement issues, abuse. And then Mr. Pallone and I and others, Mr. Pitts and others, authorized the National Prescription Drug Monitoring Program. And ever since, as you've indicated in your testimony, ever since we started the program, we've had difficulty getting the necessary appropriations. And we still are having difficulty doing that. We tried to merge the programs, and we've had some difficulty even doing that. But I guess the good news is that it's my understanding that now 47 states do have a prescription drug monitoring program. Certainly they're not all the same. But in your testimony, I think you referred to in Ohio in the emergency rooms that you said 40% of providers, based on information they received on the prescription drugs, changed their prescription orders?
Right. So in that particular study, they found that 43% of prescribers produced less or prescribed no opioids at all based on the information they received. There's a second side to that, though. When I and my colleagues practice, there are quite a number of times when we look in the database and find that a patient has received no opioids ever. And in fact, that helps to validate and help us to feel more comfortable that a short course of treatment is appropriate in that patient. It helps both ways.
Yeah. Well, do you feel that the NASPER program in Kentucky is doing well, or do you have any suggestions of how we could improve it? Or
so the NASPER program in Kentucky has come a long way. As recently as 2011, there were strong prohibitions in who could see it, who could share it. I couldn't enter it in the medical record. That has rapidly evolved, as you know, with House Bill 1 in the state of Kentucky, and then the legislation the following year in 2013 that made some corrective actions. So I would say that the NASPER program in Kentucky is evolving well. It did teach and show, I believe, something we feel strongly about, which is these tools are so rapidly evolving and are so uneven and heterogeneous across the country that mandating the use of these programs is not the appropriate approach, that in fact, if we would work to standardize them, make them interoperable, and have real-time data, meaning I ask the database for an answer and I get it quickly, that the clinicians will use these tools when they function well, and we're only just beginning down that path.
So you don't think mandating is necessary then?
I don't think so. I think with countless other things, physicians have shown when the technology works and helps patients, we adopt it.
Yeah.
And when it's broken and doesn't work, we generally don't find it useful.
Yeah.
We're getting to a better place, but NASPER is essential because the states are so all over the map for the immaturity of their programs and the fact that they don't communicate with each other yet, that the relatively small investment on the federal government could help to jumpstart a profound evolution and advancement in these programs.
Yeah. Well, I really appreciate your taking time to come up and talking about it. As I said, we appreciate the issues that all of you have discussed. And as we move forward, Dr. Stack, maybe we could get together sometime and get some additional ideas from you on ways that we can try to merge these programs so that they can be as efficient and technologically advanced as possible.
The AMA is definitely committed to working on this issue, and we'd be happy to do that.
Thank you so much.